And a good day to you, future nurses. We got cut off last time before we had a chance to talk about the treatment of pneumonias. So we'll start first with a discussion of the treatment of acute exacerbation of chronic bronchitis. You will remember that we said that the clear majority of cases of bronchitis are caused by viruses. Therefore, antibiotics are not the mainstay of treatment, and they may even increase adverse events and antimicrobial resistance. So then with bronchitis, you want to suggest symptomatic treatment, rest, antitussive medications, and bronchodilators if necessary. If, however, you have acute exacerbation of chronic bronchitis, then you're probably dealing with a bacterial infection. So the symptoms of such a thing are increased difficulty breathing, increased production of sputum, and an increased purulence of that sputum. The sputum gets darker colored. The sputum starts to have blood in it. There's more of it. Perhaps you can culture bacteria from it, and the difficulty breathing gets worse. Now, the microorganisms involved are usually Haemophilus influenzae, typically non-typable, or maybe other strains besides the B strain, Streptococcus pneumoniae, Moraxella catarrhalis, enteric bacteria, so the enteric gram-negative rods, Chlamydia pneumoniae, or Chlamydophila pneumoniae, or Mycoplasma pneumoniae. Pseudomonas species should also be suspected if your patient has particular risk factors. So if they have bronchiectasis, if your patient has been subjected to chronic steroid use, long-term steroid use, and if they have multiple recent antibiotics, or frequent hospitalizations. Then Pseudomonas species are a definite possibility. So typically, you will treat, because you want to make sure you treat with a drug that will hit these organisms that are not susceptible to beta-lactams. Your drugs of choice usually are azithromycin. Azithromycin has the added benefit of decreasing inflammation in the airways. How this drug causes that is not clear, but it clearly does staunch inflammation, particularly in the respiratory system. So you treat 3 to 10 days unless otherwise noted. So for azithromycin, you treat with 500 mg for 3 days. Or if you use a Z-Pak, the Z-Pak has one, well, it's with a first day dose is usually 2 pills. So both pills are 250 milligrams. So you do 500 milligrams the first day, then you go the next 4 days, 250 milligrams. That's a Z-Pak. The other alternative is doxycycline, 100 mg, BID, 3 to 10 days. You can also treat with cefuroxime. This is good for Streptococcus pneumoniae or Moraxella. 500 mg BID, 3 to 10 days. Or levofloxacin, 750 mg for 5 days, or moxifloxacin, 400 milligrams for 5 days. And then other drugs that can work are sulfa drugs, trimethoprim, sulfamethoxazole, 1 tablet twice a day. And your patient may also benefit from bronchodilators. So beta-2 agonists, levoalbuterol, albuterol, drugs like that. Those are the main short-term beta agonists these days, or albuterol, levoalbuterol. Pyrbuterol and the others are not being manufactured anymore. And then inhaled corticosteroids. Fluticasone is probably the one that's used the most. There are others. There's budesonide. There's several others, triamcinolone, what have you. There's many of these are over the counter, and you can ingest these. Beta-2 agonists are by prescription. Now, what is one to do with pneumonia? If you have a patient who is healthy, you're treating a community-acquired pneumonia. So the main culprits here will be Streptococcus pneumoniae, Haemophilus influenzae, usually typable, Mycoplasma pneumoniae, Chlamydia or Chlamydophila pneumoniae, or perhaps Legionella. And it's clear, it's bacterial. Then your drug of choice is usually azithromycin. And you're going to use the Z-Pack, so 500 mg the first day, 250 the next 4 days. This will hit Legionella, Mycoplasma, Chlamydia, Chlamydophila, and it also hits Haemophilus influenzae and Streptococcus pneumoniae. The alternative would be doxycycline. Doxycycline. 100 milligrams, and you'll give that twice a day, and you usually treat for about 5 to 7 days. So this would be low risk for drug-resistant Streptococcus pneumoniae. That's your standard outpatient treatment for pneumonia, and if you work family practice, something like that, this is usually what your go-to will be for people with pneumonia. And you're going to want to make sure you follow up to make sure that this treatment worked. If you have significant comorbidities, now things get more complicated. So what might be those comorbidities? Well, if they've had antibiotics in the past 3 months, if your patient has diabetes, and in some cases, keep in mind, it might be undiagnosed. If they have active cancer, if there's immunosuppression, either the result of drugs or the result of some sort of genetic condition, or if there's liver, or if there's lung, renal, or heart disease. Now your treatment options just got more complicated. Okay, so usually your first go-to drug is going to be amoxicillin, clavulanic acid, so that's augmentin. So you can either go with the 875 BID, or there is a extended release version that's 2 grams, which you can give. That way it's only once a day. Oh, I forgot to mention, if your patient's an alcoholic, that is also a comorbidity. So you'll either use augmentin, or you might also use ceftriaxone. That's 200 milligrams, that's BID. Now, to this, you're going to add azithromycin or doxycycline at the dosages noted up here. So you're going to combine this one with this one, either augmentin with azithromycin, or augmentin with doxycycline, or ceftriaxone with azithromycin, or ceftriaxone with doxycycline. Or alternatively, you can combine them with a fluoroquinolone as well. That is a possibility as well. So, or the fluoroquinolones. Okay, I'll learn how to spell one of these days. Fluoroquinolones. So that would be levofloxacin, 750 mg QD, moxifloxacin, 400 mg QD, both of those for 5 days. And with the and you will treat these. So usually, again, you're also going to treat for 5 to 7 days, just like you would up here. Now, this is the case if you don't suspect Pseudomonas aeruginosa and if it's still an outpatient sort of situation. What do you do if it's inpatient? If it's inpatient, but it's not ICU, then you're going to go to intravenous drugs, and your drug will be ceftriaxone. Plus azithromycin or doxycycline. And then alternatives, of course, would be the fluoroquinolones. And what if you have the patient in the ICU? Well, in the ICU, you have the MRSA risk. So if MRSA is suspected, your go-to is vancomycin. And with vancomycin, you can only give that intravenously. If you give it orally, it's not absorbed. So with this, you do what's called a loading dose. That's to make sure that your drug levels, you're not waiting for your drug levels to get up. Your drug levels jump up, and then they will stay high. 25 to 30 mg per kilogram body weight. And then you go to the standard 15 to 20 mg per kilogram body weight. Alternatively, you can give linezolid, 600 milligrams BID. And then what do you do if you have a Pseudomonas risk? Now, if they have Pseudomonas pneumonia, it's a pretty safe bet they're in the ICU. Pseudomonas pneumonias tend to be pretty aggressive. Should also say a risk factor for Pseudomonas pneumonias would be patients with cystic fibrosis. Okay, so your drug regimes now get a little more complicated. So your first option is going to be levofloxacin because the fluoroquinolones have good activity against Pseudomonas. I misspelled Pseudomonas. So levofloxacin. The other option would be ciprofloxacin. Use ciprofloxacin, which is not quite as active. You're going to use 400 milligrams, but that's going to have to be 3 times a day. And you're going to add to this cefepime, which is a drug that's specialized for Pseudomonas, 2 grams TID, you're going to have to give a lot of it, or piperacillin. And tazobactam. And that's 4.5 grams. You have to give that 4 times a day. That's your go-to cocktail. There are other things. For example, if fluoroquinolones are not an option, with the cefepime or piperacillin, you could also potentially give gentamicin. And you give that at 5 to 7 mg per kilogram body weight. You usually combine that with azithromycin. Uh, 500 mg, of course. And then you combine these two with the cefepime or piperacillin. Now, if your patient has a bad penicillin allergy, you can't give them cefepime, you can't give them piperacillin. Then if you have a Pseudomonas infection, then you'd give gentamicin, as already specified, 5 to 7 grams per kilogram body weight, plus estrianam. And estrianam, remember, is a monobactam. There's no cross-reactivity with penicillins or cephalosporins. You give that 2 grams 3 times a day. Remember, For cystic fibrosis patients, there's an aerosolized form of this called Caistin. So they'd inhale this. This is very effective for cystic fibrosis patients. So Strianam, and then also you would add your fluoroquinolones. Either levofloxacin or potentially azithromycin. And then if MRSA is suspected, then you add vancomycin or linezolid if MRSA is suspected in addition to Pseudomonas. So if that seems complicated, that's because it is. All righty, what do we do for aspiration? Your aspiration pneumonias? Okay, remember, these are often mixed infections, and these will very often have anaerobes. So you'll have gram-positive bacteria with gram-negative bacteria, and you usually have to give drug combinations. You have to give the big guns, typically. So for the anaerobes, usually your drug of choice is going to be clindamycin. That's going to be 600 mg. Another treatment option that tends to be pretty wide-ranging is this stuff called Unisys. What is Unisys? Unisys is ampicillin plus sulbactam. What's ampicillin plus sulbactam? Ampicillin, you'll remember, is a beta-lactam. It's one of the aminopenicillins. This drug is poorly absorbed orally. Amoxicillin is a drug you give orally. Sulbactam is a beta-lactamase inhibitor, just like clavulanic acid, just like tazobactam, so on and so forth. So this has to be given intravenously, and this is 3 grams, and you give it 4 times a day. Other options to hit the, so these two, you'd combine these two. Other options to treat the anaerobes would be to combine with metronidazole. Excuse me. Metronidazole is an excellent choice for your anaerobes. This comes as an oral or an IV formulation. So if you give it IV, it's 500 mg, and that's twice a day. And then you're going to add to metronidazole, because metronidazole is pretty specific for the anaerobes. You're going to combine that with ceftriaxone. And if you have a penicillin allergy, you use metronidazole plus a fluoroquinolone. If there's a penicillin allergy. All right, that's more or less your treatment schemes for aspiration pneumonia. We already went over healthcare-associated pneumonia So I don't think there's need to talk a whole lot more about that. And that is the treatment of pneumonia. If you have any questions, you can email me your questions, and I will do my best to answer them.